So I have the honor of introducing Dr. Miguel HERNAN as this year's Public Health Forum speaker. And for most of us, especially those in epidemiology as well as others, Miguel needs no introduction, but nonetheless, I'll introduce him. He's professor of epidemiology and of biostatistics at Harvard and associate director of the Harvard School of Public Health program on causal inference, as well as an affiliated faculty member at the Harvard MIT Division of Health Sciences and Technology. So he's 3 times a doctor with an MD from the, I can't say this, Universidad Autónoma of Madrid, Spain. And he holds doctorates in both biostatistics and epidemiology from Harvard University.
Only in epidemiology.
Pardon me?
Only in epidemiology.
Okay, well it says, it says biostats.
That's a master's.
Oh, master's, okay. He's also quite modest. So Professor HERNAN, we know him from his great contributions to methodologies for causal inference from observational studies, so how we can try and analyze them as though they were randomized experiments. He has over 150 publications and also a book on causal inference with Jamie Robbins that's in print this year, right?
Hopefully.
Potentially. But if you haven't seen it, it's available for download from his website, so it's really a great resource. He's also the co-PI of the HIV Causal Collaboration, which is a multinational collaboration of prospective cohort studies of HIV-infected individuals from 6 European countries and the US. And this work uses some of the novel methods that he's brought to EPI and helped to establish, including inverse probability weighting of marginal structural models, G-estimation. So we're really honored to have him here today, and he has a great title, Epidemiologic Methods Are Useless, They Can Only Give You Answers.
Thank you, Susan. So I am very honored to be here, and wow, to see all these people here. So now, no pressure. So this is the title of my talk, as Susan said, and really this is copied from something that Pablo Picasso said. He said that computers are useless; they can only give you answers. And of course, that was easy to say for him because his funding didn't depend on computers. But I try to make a living out of epidemiologic methods, and I'm actually doing it. So, so really, the problem that I like to discuss here is the fact that we are using more and more complex methods. So every new year, there is a new fad that we follow, and we talk about now marginal instructional models or things like that. And in the past, we're talking about the propensity scores or instrumental variables. So there are all these fancier and fancier methods that we are using, and some of us are responsible for those, as Susan was saying. The problem is that sometimes we get so fixated on the methods that we forget what the questions are, what the important questions are. And I think that is a problem. So the talk could have been titled something like this, Asking the Right Questions. But then maybe not so many of you would have come. But this is really about that. It's about what questions are we asking. The methods are a secondary part if we don't think about the questions first. Well, so let me give you an example of a question that is not a good question. So we can read this. A young couple moves into an apartment and decides to repaper the dining room. They ask the neighbor who has the dining room the same size, how many rolls of wallpaper did you buy when you papered your dining room? 7, he says. So the couple buys 7 rolls of expensive paper and they start papering. When they get to the end of the 4th roll, the dining room is finished. Annoyed, they go back to the neighbor and say, we followed your advice, but we ended up with 3 extra rolls. So, he says, that happened to you too. That is an example of a wrong question to ask. Okay? And what I'm going to argue here is that sometimes we ask questions that have this flavor, even though we are not always asking the questions that we want to ask. So, to do that, I'm going to go over 3 examples. The first example is when we want to estimate the effect of antiretroviral therapy for HIV-infected patients on death. And that's an example where we actually need fancy methods to answer the question. And that's where all these new things come into the picture. In the second example, is going to be one in which we don't need fancy methods to answer the question, and that's hormone therapy and heart disease, an example that I'm sure many of you know too. And the third example is when we don't even know what the question is clearly, and that's when we try to estimate the effect of lifestyle on heart disease. So in each of these examples, we are going to see different features of questions that we ask every day as epidemiologists and the problems that we encounter with each of these questions and methods. So let's start with the first one. When we ask the question, what is the effect of combined antiretroviral therapy on the mortality of HIV-infected patients? This is a relatively well-studied issue, and we now know, of course, from trials and from observational studies that antiretroviral therapy works. Here, I'm going to show you very, very briefly something that we did with the HIV causal collaboration. These are people from who have HIV and are from Europe or the US. And the problem that we have when we try to answer this question with observational data is that we have a time-varying treatment, which is antiretroviral therapy. People may start therapy at different times, so it changes over time. They start at different times, every person at different times and for different reasons, and those reasons are the indications for therapy. Those are the confounders, so the confounders are also time-varying. We have time-varying confounders, we have time-varying treatment, and even worse, the time-varying confounders are affected by whether you have been on treatment or not in the past. So we have time-varying confounders affected by time-varying treatment, and this feedback loop that we have makes it impossible for conventional methods to estimate the effect of a treatment on the outcome of interest. This is now a well-known problem. It was first described by Jamie Robbins in 1986, and many of the methods that he and others have developed are precisely to handle this feedback that we get between confounders and treatment. So in this case, just to give you something to fix ideas, the hazard ratio for therapy on mortality, the hazard ratio of mortality for therapy versus no therapy is 1.4, where we don't adjust for anything. And that is expected. There is lots of confounding. People who start therapy are people who are worse off. So if we don't adjust for confounding, it looks like therapy is bad. When we adjust for everything that we have at baseline, all the baseline confounders, things like the C4 count at baseline and the viral load and whether the person was infected through gay sex or through drug use or the country, sex, age, everything that we have, then the hazard ratio goes down from 1.4 to 0.8, which is a big change. Now, we have more confounders in the data. We have confounders that are measured after baseline, the time-varying confounders. We have the C4 count at any time after baseline, at every 2 months after baseline, and we have the viral load. When we adjust for all those things on top of the baseline confounders, we add those covariates to the model as time-varying covariates to this Cox model, then the hazard ratio doesn't change. In fact, if anything, it goes in the wrong direction. So this doesn't make any sense. We are adjusting for more confounding. We would expect that the hazard ratio keeps going down as we keep adjusting for confounding, but that doesn't happen. We can show this mathematically. We can show this in a simulated data set, or we can see it in real data, like here. And this is exactly the problem, is that the Cox model or any other method that just puts the confounders in the model for the outcome cannot handle these time-varying confounders. There is some, it is adjusting for confounding, at the same time it is creating some bias that in this case seems to more or less cancel the effects of the confounding. So we can make no progress here. This is the case where we need something like IP weighting of marginal structural models of some of the other G methods. If we use those methods, then the hazard ratio goes down to 0.5, which is more in line with what we would expect from randomized trials, so from other data sources. So this is just a very simple example that I'm doing first just to justify my job, which is there are some cases where we need these methods, but not always. And this is a very good example because this has been seen with every single HIV cohort, essentially, and it is well accepted now for those of you who are here who are working on HIV. It is if you go to a meeting where there are cohorts of HIV patients, these methods are now widely used, and some of you are using them. So this is just what I said. This is just an example that when we adjust for the time-varying confounders using the standard method, we don't do better. In fact, in some cases, not here, but in some cases we do worse. In some cases, it is better not to adjust for time-varying confounders if we're using a standard method like a Cox model. Just adjust for the baseline confounders, period. That's even better. If you are going to adjust for time-varying confounders, then these other methods are the ones that are going to help. OK, so that was the first example. That's a simple one. I'm not going into, in the interest of time, I'm not going into what IP weighting is and things like that, but it's really not necessary for the purposes of this talk. Now, the second example where I'm going to spend a little bit more time is the case of hormone therapy and heart disease. So this is an example in which the question is, what is the effect of hormone therapy on the risk of coronary heart disease in post-menopausal women? That's a very well-defined question in principle. I'm sure that you all know this, but very quickly, for those of you who were living on a different planet for the last decade or so. In the 80s and 90s, there were a lot of observational studies looking at hormone therapy and coronary heart disease. And most of these studies found that women taking hormone therapy had a lower risk of heart disease than women not taking hormone therapy. The hazard ratios change from study to study, and also within a study. Over time, they go from 0.3 to something like 0.7. So let's say that 0.7. One of these studies was the Nurses' Health study. A series of papers were published in the New England Journal of Medicine and other journals. In the last update in 2006, the hazard ratio was like 0.7. So a 30% lower risk of heart disease in women taking hormone therapy versus not taking it. And this is very typical. I am of many of the studies at the time. I'm not singling out the Nursing Health study, except for the reason that I am working with people from the Nursing Health study. And I'm going to show you what we found. Of course, that was a big shock when the results from a randomized trial looking at that question were published. First in 2002 in JAMA, then 2003 in the New England Journal. What people found in the trial is that actually women assigned to hormone therapy had an increased risk of coronary heart disease compared with women not assigned to hormone therapy. Like a 24% increase in risk, and this was a surprise. In fact, this trial was very difficult to start, and some of you may have been part of the team that did this trial. Among other things, this trial was very hard to conduct because many people were questioning the ethics of assigning women to hormone therapy versus no hormone therapy when we knew that hormone therapy was good. The trial was done because, well, even though in terms of heart disease, hormone therapy might be good in terms of breast cancer and other outcomes, it wasn't. So they said, let's do a trial to look at the balance of all these outcomes. And they found that even for heart disease, there was an increased risk. So the findings from the trial, to go a little bit more in detail, was that the overall hazard ratio was 1.24. This is the intention to treat hazard ratio. Or 1.23, it depends how you analyze the data. The confidence interval where the lower limit was close to 1. I'm sure you don't care whether it's 0.99 or 1.01, right? The same thing. Ken Rothman teaches you, right? So, the p less than 0.05 is not really what we look at. If you look at the trial, and this was also published in the New England Journal, in the first 2 years of follow-up, the hazard ratio was 1.5. So it seems like most of the action was happening in the first 2 years of follow-up, where women assigned to hormone therapy were having a 50% increase in the risk of heart disease. If you look at years 2 to 5, so you don't use the first few years of follow-up. You just fit a Cox model with years 2 to 5. The hazard ratio is 1.3, and if you look after 5 years of follow-up, the hazard ratio is 0.7. So this 0.7 can be interpreted in 2 ways, essentially. One way is saying, well, after 5 years, hormone therapy becomes good. And that's one way of thinking about this. It's probably not the most likely one. A more likely explanation for this is that after 5 years, we've killed all the susceptible women in the treatment arm. So we are left with the women that are not susceptible in the treatment arm. But the placebo arm has not been subject to that same process. So women in the placebo arm are normal women, and women in the treatment are super women who have not developed heart disease despite having been on hormone therapy for 5 years. So of course, after 5 years, we get a 0.7 there. And that's why we don't analyze trials by getting rid of the first 5 years of follow-up, because then we can get these weird things. The hazards cross. But the survivor curves, and that's the important thing, didn't. Okay, so women on the treatment arm, on the hormone therapy arm, always had a higher cumulative incidence than women in the placebo arm. Okay, now when people were looking at these things, at this 1.5 and they saw the contrast with the observational studies, a common response from mostly the epidemiologists was something like, well, yeah, the trial is finding that, but it is not that the observational studies are wrong, it's that they're looking at a different type of women. Women in the trial were pretty old for the standards of women who start taking hormone therapy in the real world. I think that the average age was 64 or something at baseline. So in real life, 64-year-olds don't start taking hormone therapy for menopausal symptoms. They had to do that in the trial for practical reasons, because it was the only way they were going to get power for an 8-year trial. They needed to start with relatively older women so that there were enough cases by the end of the trial. But in the observational studies, women are younger, because women who start taking hormone therapy for menopausal symptoms are women closer to menopause. They're not 64-year-olds. So when they look at the trial by years from menopause, they found that within 10 years, women who started the trial within 10 years of menopause actually did not have an increased risk. And as time goes by, so women who start taking hormone therapy more than 20 years after menopause, those are the ones who have the highest increase in risk. So this supported the view that maybe there is some interaction here, that if you start giving hormone therapy after some atherosclerosis is already in place, then you can cause a heart attack that would not have happened otherwise. And it was published. This is a post hoc analysis of the trial that was also in the New England Journal paper. The problem was that when in the observational studies, when they tried to look at this by time since menopause, they were finding 0.7, 0.7, 0.7. So that didn't explain really, that couldn't explain really what was going on. Okay, so if you ask people, why was this happening? People will say, well, this discrepancy between the observational studies and the randomized trials was happening because of the fact that observational studies are observational, or some variation of that, meaning that in the observational studies there is so much confounding. We cannot adjust for that confounding well, and that is explaining what is happening. Women who start hormone therapy, women who take hormone therapy are women who have better access to health care, have a more healthy-seeking attitude, and they are just different. And because they are different, they have a lower risk of heart disease. It's not because of the hormones, it's because of the rest of their lives. And that's why we are finding it. So that theory that is all due to unmeasured confounding, to residual confounding is a very interesting one. It's also very dangerous for those of us who work with observational data, because if you cannot trust observational studies in something like this, then when can you trust observational studies, and why should NIH fund our work, right? So that is possible. That is one theory. But we propose an alternative theory, which was that really the results that people were looking at were not comparable, because the estimates were asking, those were estimates that were answering different questions. And that we first need to ask the first question, the same question in both trials and observational studies. But let me tell you what I mean, because this is the core of this talk, really. If you have a randomized experiment, the first thing that you have to do is to state your question. And the question has to be very explicit, because you are going to have to write a protocol around that question. In this case, the question is, what is the effect of initiation of hormone therapy in women who have not been on hormone therapy for 6 months or for 1 year or 2 years or whatever the washout period was. Once you have your question, then you design your study, which you randomly assign women to either initiation of hormone therapy or placebo, and then you compare the risk in those assigned to hormone therapy versus those assigned to placebo using an intention to treat approach. That's how we do a trial. If you think about an observational study, we don't always do that, because in observational studies, one of the differences, the big difference, is that we very often have the data already. So we have the data in our computer when we are doing an analysis. So sometimes, I'm not saying that you do it, but some people do, we first compare things and look at the data and then decide what that means. For example, we can compare the risk in women who take hormone therapy, the current users, and women who don't take hormone therapy, the never users. Once we have that comparison, and we've seen it, now we can do things, say, okay, which question are we answering with this comparison? And if you think about that, it's very hard to know. We are doing it in the wrong way. We first use the data and then think about the question. So what is the question that we are answering if we compare women who are taking hormone therapy for some time, they are the current users, with women who are not? I mean, think of this. You are a woman. You are considering taking hormone therapy. You go to your doctor and you say, look, I'm considering to start hormone therapy, but I am concerned about heart disease because I have a family history and I've seen these trials and etc. So what do you tell me? And your doctor tells you, look, if I compare women who have been taking hormone therapy for some time and have survived with women who are not taking hormone therapy, it turns out that women who are taking hormone therapy have a lower risk. You look at your doctor and say, wait, that's not what I'm asking you. You are telling me that if I take hormone therapy for a while, I happen to survive, then I will be better off. See? That's not the question that we were asking, but that's the analysis that we are conducting. When we compare current users versus never users, we are comparing women who have been taking hormone therapy for some time, 1 year, 3 years, 5 years, and have not had the outcome, and with the other women. So, I mean, if we had done that in the randomized trial, the hazard ratio would have been 0.7. But we don't analyze trials in that way, because it's kind of silly. You get rid of the first 5 years of follow-up, then look at what happens, and then you have all this problem with the depletion of susceptibles, etc. But in the observational studies, that's exactly how we were doing it. We were analyzing the observational studies in such a way, in a way that would have been completely unacceptable for a trial. And that is funny if you think about that, why we are treating observational studies and randomized trials in such a different way. If we think that one form of analysis is misleading, to say the least, for a randomized trial, why are we doing it in the observational data? So our strategy was, okay, let's use the observational data. Let's reanalyze the observational data as if it were a randomized trial. We're not going to compare prevalent users with never users. We're going to compare incident users with never users, because that's what the trial did. They compare women who start hormone therapy and follow them for the point of initiation. The start of follow-up and the start of the exposure are the same time in trials. We're going to do the same thing with the observational study. We're going to start the follow-up when the exposure starts, not 5 years later, when we may have already lost some women because of the exposure. So we did that in a series of papers. The first ones were here. We did that both with the nursing health study and with some European cohorts that were also published before this. I'm going to talk a little bit about the nursing health study application here. For those of you who don't know this, the nursing health study is an observational cohort. Every 2 years since 1976, women sent a questionnaire with data on their hormone therapy use and the diagnosis of heart disease, etc. If there is a diagnosis of heart disease that they self-report, then there is a confirmation with their treating doctor, and then there is also some information about risk factors for CHC there, etc. So we use this questionnaire-based study, cohort study, to emulate a trial of hormone therapy. And we started in 1984 because 1984 is the first time that opposed estrogens are really readily available to women in the US. So the first thing that we have to do is to define what the regimes are for this, what the arms of the trial are. So the arms are initiation of opposed estrogens versus no initiation of any type of hormone therapy. So women who in 1984 start hormone therapy are here, women who don't start are here, and women who start a different form of hormone therapy are not included. We try to mimic the eligibility criteria of the randomized experiment as much as possible. It doesn't seem to be very important, but we did it in terms of prior history of stroke or cancer or things like that. And we also have a washout interval. Women would not have been using hormone therapy in the prior study period. Then we have to define what the baseline is, and this is the key. What is the baseline? Well, the baseline is for women who start hormone therapy is the time where they start hormone therapy. For women who don't start hormone therapy, that is a randomly allocated time during that period, and then we follow them from that baseline until the end of follow-up. Okay, which can be either death or a diagnosis of CHC or loss of follow-up or June 2000. We went only to June 2000 before the results from the trial were available. So now if you think about this, we have this nursing health study quote trial, which has the same structure as a randomized trial in the sense that we have two groups followed from initiation of exposure or no initiation of exposure. This is non-blinded and is not randomized. But have the same eligibility criteria, the definition of a start and end of follow-up, and the same treatment arms. It's different not only because of the lack of randomization or lack of blinding, it's also different because women in the observational studies tend to be younger, and also the follow-up tends to be longer. The average follow-up in the observational study is longer. We saw that the hazard ratio changes with these two features, so we will have to look at the results by time since menopause and also by length of follow-up. Okay, so we have this quotes trial using the observational data. Now we need to decide how to analyze the data. We do the same thing that the trial did. We do an intention to treat analysis using a Cox model because that's what the trial did. So an intention to treat analysis of observational data is of course not possible because there is no intention to treat. But we can do something similar in the sense that we compare women who start hormone therapy and women who don't. So we use only baseline exposure. We don't update the exposure because in an intention to treat analysis of a trial, you don't do that. Someone is assigned to hormone therapy, it doesn't matter that they stop taking it 3 months later. Will always be in the hormone therapy group. So that's what we did here. If a woman starts hormone therapy, they're in the hormone therapy group forever, even if they stop taking it 6 months later. And the same, if they are in the non-hormone therapy group, even if they start a day later, they are not going to be part of that group. Okay, so that's what we mean by an observational analog of the intention to treat effect. But of course, this is not a trial. This is not the randomized trial. It's an observational study, and it is true that women who start hormone therapy and women who don't are different with respect to many risk factors. So we have to adjust for confounding. It's only baseline confounding because we have a baseline exposure only. So we don't have to worry about time varying confounding. We are making all of this into a non-time varying study. These are all the variables that we could find, and we adjusted for them, and we adjusted for the history of these variables in the periods before the baseline. So everything that we could find, we threw it there. And also, we did it as covariates in the outcome model, in the Cox model, but we also did it with propensity scores, and we did it with G estimation, which is the most efficient way of using a propensity score. And we did it with different methods. It doesn't matter. The method for confounding adjustment is not important as long as you adjust for all these variables. So the results that I'm going to show you are not sensitive to which particular method we decide to use. We definitely have to adjust for confounders, or we don't find what I'm going to show you. So the point here is that we're not using any fancy methods now. We're just using a Cox model, not even time-varying treatments in the Cox model, not even time-varying covariates. It's nothing. It's just a very simple Cox model, same as the one that they used in the trial, except that we are adjusting for more things. But other than that, is that. But we've completely changed the question. We've completely changed the question for a comparison of prevalent users versus never users with a comparison of incident users versus never users at baseline. And that is exactly the question that we are interested in from a clinical point of view. From a comparative effectiveness research point of view, for any point of view, we really want to compare incident users versus never users. And this is a very simple way of doing it. There is actually one technical detail, but it's not very important from a conceptual point of view. It's important from a practical point of view, which is that when we do this for women starting in 1984, there are very few women who start therapy in 1984, so there are very few cases. So we end up with a hazard ratio with a very wide confidence interval. So we could have started this trial rather than in 1984, in 1986. We applied the same eligibility criteria and followed them from there. Or in 1988. Every 2 years there is a questionnaire. We could have started the trial at different times and choose the time when we have more power. Or we can do every single possible trial. There are 8 trials that we can do here, starting from 84 to 1998. So we can do each possible trial, estimate the hazard ratio, and then do a meta-analysis of those 8 hazard ratios. Or we could start every single trial, consider each woman in each trial as a different woman, so someone who is a non-initiator in the 84 trial and is followed all the way to 2000. In the 86 trial, that same woman is considered an initiator and followed all the way to 2000. So we can create a very large data set in which each woman is copied as many times as she is eligible for each of the trials, and we fit the pool Cox model there. We, of course, need to take into account the fact that women are contributing more than once, so we need to adjust the variance of our estimate. Okay, and that is exactly what we did. We pool across all possible trials. So it's the same idea, but see, when I told you that we are transforming a time-varying treatment into a baseline treatment, that's true. That's a simple way of doing it. But at the same time, it's really a time-varying treatment, and we want to exploit all that information. So one way of doing it is by doing these nested trials, essentially. What we are doing now is really the poor man's version of G estimation. It's a very simple way of doing structural nested models without having to use G estimation, really. But that is all that is going on here. Okay, so when we do this, we find there are 34,000 women that meet the eligibility criteria at some point during the follow-up, 1,000 cases. Now, because we are pooling overall trials and women are contributed on average to 4.4 trials, we really have a data set with 152,000 women and 3,600 cases. Okay, we do this, and this is what we find. This is what we found. the trial had an overall hazard ratio of 1.23, we had 1.05. But we cannot directly compare these two because of the different distribution of time since menopause and time since and time of follow-up. So if we look at the first 2 years of follow-up, in the trial, it was 1.5. We're finding 1.4. Very similar confidence intervals. The width of the confidence intervals is very similar. After 2 years, it's 1.1 versus 0.9. Within 10 years, women who are within 10 years of menopause at baseline, we find no increased risk in either the trial or the observational study. 10 to 20 years, 1.2, 1.1, similar. More than 20 years, there are really no women in real life that start more than 20 years after follow-up, so we cannot compare that. See, if you look at this, at the comparison, now that we're asking the same question, or a much closer question in the trial and the observational study, you see two things. One is that there are no shocking discrepancies. The second thing is that the confidence intervals are wider now. Both the trial and the observational study have very similar standard errors, actually. But we didn't use any fancy methods. We just were using a baseline Cox model with baseline values, doing it in different trials. Nothing very complicated, but we completely changed the question. And once we are asking the same question, results are much closer. No one would have said, this is the end of observational epidemiology. No one would be writing in every single editorial, in every clinical journal, every time there is a commentary on an observational study, even if it is on Parkinson's disease or multiple sclerosis or HIV, it doesn't matter what they are talking about. They will say, oh, but be careful, because this is an observational study and you know what happened with hormone therapy. That has become something that it seems like you have to write that down if you are writing later. But if we had compared the same things in the trials and the observational studies, that could not be happening. People would be saying, well, you know, they're similar, the confidence intervals are wide in both, but it seems that there is an increased risk in the first 2 years, nothing in women than 10 years. It's not that different. So we think that that's a good alternative explanation to what happened. That doesn't mean there is no confounding. Of course, there may be some confounding. I mean, it would be silly to say, I have an observational study with no confound, with no residual confounding. Yeah, probably. But the confounding by itself could not explain the difference from 1.2 to 0.7. That's too big. Something else was going on here. Okay, now one point that I want to make here, because sometimes this is misunderstood, is that I'm not saying that we should analyze observational studies using intention to treat analysis only. I'm doing it here just for the comparison. In fact, I'm not saying that we should analyze randomized trials using intention to treat analysis only. Okay? That's a good first step, but then we have to adjust for non-compliance or for time-varying confounding. Time-varying confounding in observational studies is what people in trials refer to as non-random non-compliance. It's the same concept. So we need to adjust for those things if we want to estimate what would have happened if people had complied, etc. And we actually did that with both the observational study and the randomized trial. We did that. We published that a few years ago. It didn't change things much. I mean, we still have no big discrepancies between the trial and the observational studies. Okay, so that was the second example. Is when we don't really need fancy methods, we just need to focus on the question. And of course, if you read pharmacoepidemiology papers, they're all talking about this now. Since Wainwright talked about in 2003, the new user design, that's what people tend to do now. And they're talking about new user design. What I show you here is the general version of the new user design when you have a time-varying treatment. And that is what stems from Robin's theory. So the last example is the most complicated one, because this is an example in which we have time-varying confounding, we have time-varying treatments. We probably need to use a fancy method, but we don't know what the question. So let me show you. Let's say that unlike in the other two examples, the question of interest is not well defined. Okay, and also we don't have a randomized trial to cheat, because some people say, oh well, in the other two examples you knew the right answer before you were doing it. That's easy. What what happens when we don't know what the right answer is? And in fact, we don't even know what the question is. So think of the questions that we ask about the causal effect of cigarette smoking, alcohol, physical activity, diet, BMI, on the risk of CHD. Okay? What do we really mean by the effect of BMI? What do we really need by the effect of physical activity? All these questions need to be expressed in terms of hypothetical contrasts, counterfactual contrasts. Or, another way of saying it, we need to know what is the hypothetical randomized experiment that we would conduct to answer these questions. That's how we know that the question is well defined. When we can think of a hypothetical trial to answer the question. It may not be a feasible trial. It may not be an ethical trial. It may not be a trial that is ever going to be conducted. But if we can conceptualize our question in terms of a trial with full compliance and analysis to follow up, that is a well-defined question. Once we start to deviate from that, then we start dealing with questions that are not as well-defined. In the case of many of these exposure, we're never going to have large, long-term trials of lifestyle that where people are actually doing it. So what we did here is, again, we work with our colleagues from the nursing health study, and we used as a starting point a paper that was published in the New England Journal in 2000, where women in the nursing health study were defined as low risk if they were doing all these things. They were not smoking, they had a BMI under 25, they drank a little bit of alcohol, they were physically active at least half an hour a day, and they have a good diet measured by some dietary score that they were using. Women who were doing all these 5 things were considered to be at low risk. Now, what we need to do here is first we need to define what is the causal question here. What does it mean to be a low risk? And to do that, we need to think of the hypothetical interventions. We also need a fancy method because this is very complex and there is a lot of feedback between all these variables. In this case, rather than IP weighting for practical reasons, we use the parametric G formula, which is not the point of this talk and is not very important, as you will see. And there is a series of papers that have been published on this. The first one was in the IAE in 2009. So, to define the interventions, we need to define not only what the actual intervention is, but also when it starts and when it ends. So in this case, we defined, we said we are going to estimate the 20-year risk of coronary heart disease if all women in the nursing health study had followed each of these interventions starting in 1982. So starting in 1982, all women stopped smoking, if they were smoking. All women exercise at least 30 minutes per day. All women drink a little bit of alcohol. All women keep the diet score that they have a BMI less than 25. So we are going to estimate the 20-year risk if all women did that. If all women did that. If all women did that. Then we are going to look at all the combinations, or some of the combinations of these things. And we're going to compare that risk with the actual risk that was observed when women were doing whatever they were doing. So the comparison of the risk under the intervention with the comparison of the observed risk is going to tell us which interventions give you more benefit compared to doing nothing. Okay? And we're going to make these 3 assumptions for now. The assumption of no residual confounding, the assumption of no measurement error, and the assumption of normal misspecification. Crazy assumptions in this case, all of them. But let's just make them for now, and we'll discuss them. So I'm jumping into the estimates. We estimated this. We estimated, well, first, if women, we don't intervene, we just see what happened to women over 20 years, they have a 3.7% increase in risk, 3.7% increase in the risk of heart disease. Sorry, not an increase, that's the absolute risk of heart disease over a 20-year period is 3.7%. If all women had quit smoking at baseline, we estimated that the risk would have been 3%. So the risk ratio is 0.8. If all women had exercised at least 30 minutes per day, then we estimated 2.9%. Again, a 0.8 risk ratio. If we combine all these things, if all women had done everything for 20 years, we estimated 1.9%. So that's a risk ratio of 0.5. That means that 50% of the cases of heart disease would not have happened if 4 women had done all these things for 20 years. See, we have now defined what our intervention is very well in terms, a little bit better in terms of when it starts, when it ends. So 49% of cases would not have happened. In the New England Journal paper, the number was 82%. It's much higher, but the comparison is not fair because we were using more updated data when we did this. So if we apply the methods of the New England Journal paper, without the usual method, just fit the Cox model and things like that, then it would have been 67%. So it's really 49% using these fancy methods versus 67% using a normal method. And now we could get into a discussion of which method is better. But I'm not going to do that because from a practical point of view, from a public health point of view, who cares? 49%, 67%, huge. Both numbers are huge. If we can, if we can make disappear 50% of the cases or 67%, that doesn't change anything really. So there is a very strong effect of lifestyle. That's what we find using either method. Okay, and the question is, how seriously should we take this? If we are now start thinking about what we have done, is this for real? Do we believe it? We know that the assumptions that we are making are not true, but how serious is that? So let's say first the assumption of no unmeasured confounding. We have used this G-formula method that can adjust for time-varying confounding, for measured time-varying confounding, even if it is time-varying confounders that are affected by prior treatment. So we are taking care of that. That might explain the difference between the 49% and the 67%. But there would be some unmeasured confounding. For example, look at the results. Maintain BMI less than 25. We estimated that if all women had maintained their BMI at 25 or less for 20 years, the risk would have been 3.6%, essentially the same as if we do nothing. So either BMI has no effect on heart disease, changes in BMI have no effect on heart disease, that is one possibility, or this is completely wrong. And why can this be wrong? Maybe there is unmeasured confounding. Maybe women who lose weight in our study are women who are sicker. They have some subclinical disease that makes them lose weight. And what we're finding is that women who lose weight are sick and therefore are more likely to have heart disease, and we cannot adjust for that. So if that is the case, then we shouldn't take this very seriously. And in fact, most people don't. But if we believe that, what happens with exercise? Because if that type of confounding is there, that means that women who are exercising are probably women who are not sick. And therefore, we are now overestimating the effect of exercise. So if we are internally consistent and we dismiss what we are finding for BMI, that means for the same reason we have to dismiss the beneficial effect that we are finding from physical activity. So that leaves us in a very hard position, because do we believe there is no effect of weight loss, or do we believe that there is no effect of that? Okay, so that is one of the problems that we have now when we don't have a benchmark. And of course, what we tend to do, what many of us do, is we pick and choose what we like and we not. And physical activity, oh great, we're finding exactly what is right. For weight loss, we are not. Oh, something must be wrong with the data. So that is one problem. The other problem is that is measurement error. We have lots of measurement error here. We have measuring diet, physical activity. Of course, we have a lot of measurement error. So people will say, well, yeah, we have measurement error, but despite the measurement error, we're finding a signal. So the true signal must be even bigger. Well, that doesn't apply now. That type of reasoning doesn't apply when we have time-varying treatments and confounders, because with time-varying treatments and confounders, the measurement error affects the confounders too. So we have measurement error. It's not only in the exposure, it's also the confounder. So maybe what we're finding is due to unmeasured confounding, to the fact that we are not being able to adjust for confounding well. And that is very complicated to look at here. Model misspecification. I didn't gave you the details, but to fit the G formula, we have to fit a lot of models. And you need models for the exposure, models for the outcome, and models for each of the confounders. So if you have 20 confounders, you have 20 separate models, one for each of the confounders. Okay, we have to do that for these two work. I mean, it's almost impossible that these things are all correctly specified. And in fact, it is impossible because once we are using cohorts like this, when we have questionnaires, when things are measured every 2 years, then it's impossible to discern the time sequence. If you measure diet and BMI and physical activity every 2 years at the same time, which one came first? It's impossible to know. So you have to do a lot of sensitivity analysis. I mean, this is true for every interval cohort, for every cohort that is based on getting information every 6 months or 2 years or 4 years. It's a big problem. We don't know what comes first, and we can only deal with that with sensitivity analysis, or by acting as if there is not a problem, of course. Now, despite all of these issues, I think that there is a contribution of this type of analysis. Not so much because of the fancy method, but because of the fact that we are specifying the question of interest in a more precise way. And that has advantages, because once we make the hypothetical interventions, we make them as explicit as possible, then we find very interesting things. For example, say this column here is the proportion of people whose data are not consistent with the intervention. So that means that 30% of the women in the nursing health study did not quit smoking throughout the entire follow-up. Okay? Now, 99% of women in the nursing health study did not exercise 30 minutes per day during the entire follow-up, which means that when I'm giving you an estimate of what would happen if women had exercised for 30 minutes every day during the follow-up, I am interpolating a lot. But look, 100% of the women did not do those 5 things for 20 years. But I gave you an estimate. I am extrapolating now from the data. I'm using my models to extrapolate from the data. But the New England Journal paper was doing that too. It was just harder to see because the interventions were not specified as here. This is a starting point, this is the end, etc., etc. So it turns out that for many questions that we ask, we are extrapolating from the data to a certain extent, and it's good, but we can only see that if we define the intervention first. Then we may like it or not. Now we may look into this and say, well, fine, we are extrapolating, but that's the only thing that we can do if we want to answer these questions, and we can live with that. And we know that. We know what we are doing now. But it's even better when we make the hypothetical interventions explicit. Now, not only we know what is the degree of extrapolation, but also we see that some of the interventions are not interesting. Think of the BMI intervention. This is what I said. I said, starting in 1982, all women go to a BMI of 25 or less. That means on December 31st, if a woman is at a BMI of 32, that woman goes to 25 or less in 2 minutes. It's not possible. Why would you want to estimate that? First, it has no public health relevance because it is impossible. We cannot do it. We have no way of doing that. And second, it's not only the public health relevance. It's that it's impossible. It's just we don't know how to do that. I mean, maybe we can do that if we chop her 2 arms on that day, right? But that is not that's not of interest from a public health point of view. So once we start looking at this, say, oh, maybe the intervention that we should consider if we are thinking public health now is, what if starting in 1982, women start to lose weight, say 2% of their body weight every year, until they reach a BMI of 25 or less. Okay, now that is a more reasonable intervention, but we cannot even think of that until we specify what our intervention is. If we compare just BMI greater than 25 or BMI of 30 versus BMI of 25 versus BMI of 20, what intervention are we comparing? See, we are back to the point where we were comparing prevalent users and never users. Now it's prevalent people with a prevalent BMI of 30, with people with a prevalent BMI of 25. We have no idea how they got there. We have no idea. We're not comparing, we're not giving a public health message. We're saying if you're fat, you have a higher risk of death. The public health message is if you lose weight, you have a lower risk of death. That's not what that comparison is doing. Okay? It's possible that women are at that level, and now even if they lose weight, they might not have an increased, a decreased risk of heart disease. Maybe they lose weight from their waist, but their coronary arteries are already screwed, so they are going to have, sorry for the technical term, but they can get there. So see, that the same logic applies also to public health, except that now things are much harder. If now we want to ask questions, public health questions, using the same criteria that we were using for medical questions, it becomes harder, because a lot of these questions are based on interventions over a long period in which we have to define, it's not a yes-no, it happens over a time, etc. So, so that is, but this is a very important difference between randomized experiments and observational studies. In randomized experiments, we cannot get away with that sloppy thinking, because we have to have our question, design our study, we have a protocol, etc. In observational studies, in principle, we can look at the data, many of us, again, I'm not saying that you do it, but some people do. You look at the data, see what you find, and decide what to study or not to study, and what to adjust for or not, based on the results. And that is dangerous, to say the least. And that difference between observational studies and randomized trials may be as important as randomization. We tend to think, oh, observational studies are worse because of randomization. Yes, that's part of it. But I would say that even a greater danger is the fact that we can look at the data and decide based on what we find. Okay, so what we try to do is to always think of a hypothetical randomized trial that we would like to conduct but can't, and try to model our analysis for the observational data to try to mimic that trial. And that helps. That helps to have a clearer question, which is the main point here. Okay, so I gave you a couple of success stories based on medical data. And in medical data, well, we have medical treatments. It's easier to do. And also, we sometimes have trials to check, either before or after the fact. So we can learn from that. For public health exposures, things are much harder, because we don't have trials, because we don't have sharp questions a lot of the time. So I want to finish here. So to finish here, we need to ask the same question if we're going to compare observational data with randomized trials. And the observational studies may be flawed, may have problems. I'm not saying that they are perfect and we're always going to find the same thing as in the trials. But if we don't ask the same question, the comparison with trials is pointless, because we are not comparing apples with apples. And the second point is that the complexity of the causal questions that we're asking every day is sometimes underestimated. A lot of it, even the effect of BMI, is a very complex question. And it's very hard to frame that question in an internally consistent and precise way. But all of this is even if we don't consider the complexity of the method. So the emphasis on the complexity of the method is sometimes a way of helping us not to think about all these other problems, which are really the hard problems. And then, of course, we talk about the methods, and I get my salary paid and all these things. But that is not the most important part. So you laugh when I show you this. But really, some of the questions that I show you there for lifestyle don't strike me as very different from these questions now. Okay, so I'm going to finish here with this. Something that conference said is that, so in 1959, I wasn't born there, enthusiasm for the newer statistical tools were deserved should be tempered with recognition of the importance of insight, imagination, and intimate knowledge of one's field. And that is really the message here. So there is nothing new under the sun. People have been saying this for decades. And we just need to keep it in mind, fresh in mind. So thank you very much. happy. I'm sorry that I went a little bit over time. But
you know, the American Journal of Epidemiology has been called by some the American Journal of Fruits and Vegetables. And I wonder, you know, your third example is really challenging because what are your recommendations for looking at lifestyle exposures? It seems like we're not quite there yet.
yeah, it is really, really hard to look at a lot of these things. Diet is one of the most complex exposure we can look at. We have measurement error, we have confounding, model misspecification, and on top of that, many times we don't frame the questions in the way that we want. So there is a movement now towards asking questions. When we ask questions about diet for public health, framing those questions in terms of foods rather than in terms of nutrients or the components of the foods. I was reading the New York Times yesterday, and Frank Hu from Harvard was saying that this thing about looking at, well, you should eat more fatty acid of this type or more things like that. What is the public health message here? You are telling people eat more of this, but that people know. So now we are talking more and more about foods. You should eat more fish or less fish. Once you get there and you think about the question, you should eat more fish. Okay, what does that mean? It seems simple. More fish. So I eat my normal diet and then a serving of fish? No. You should replace your fish by something. Oh, by what? Is it the same if I replace my red meat by fish, or my chicken by fish, or my eggs by fish? And all these things, I mean, we can try to handle that, but the first step is to see how complicated these questions are, and to state the actual question is, I want to eat more fruits and vegetables, and less what? Because the effect it may be different. And when you look at many of the tools of nutritional epidemiology, they are not really equipped to handle these complex questions. So that is where things like the G formula come into the picture. We just published in the American Journal of Epidemiology a paper on fish intake. And that's why I'm thinking. And we compare eating more fish